Hey everyone, this is Koi Than from Duke University, part of the Virtual Global Spine Conference team. And today I'm super excited to have my friend, Dr. Bruno Saciloto, joining us from Brazil. I first met Dr. Saciloto when I was in Brazil for the Brazilian Neurosurgical Congress. And we connected there, and then Dr. Saciloto spent a couple of weeks observing us here at Duke, and we just became great friends, and we've continued our conversations since he's returned to Brazil. And I'm really excited to hear his talk on, why I converted from tubular to endoscopic minimally invasive surgery. Personally, as someone who does a lot of MIS surgery, I've not converted to the endoscope yet, and I'm interested to see if Dr. Saciloto will be able to convince me. So, Bruno, please take the stage, and thanks again for taking the time to join us.
Okay, Dr. Thank you for the kind words, and thank you again for receiving me at Duke's. So, my name is Bruno Saciloto. I'm a neurosurgeon here from Brazil. Today, I want to talk to you about some advances that I made in my personal practice, and why am I converting from tubular to endoscopic MIS surgery. So just to begin, I do not have any conflicts of interest, and from this talk we should expect at least a light discussion involving lumbar disc spine surgery, what to do, the definition of minimally invasive spine surgery, the comparison of different techniques and the paradigm shift, historical review, MIS and ERAS, we'll talk about it later, endoscopy and its pitfalls, and a take-home message. Should be something just straightforward. I'm not gonna involve you in long discussions and long paperwork, just to reflect a practical and a simple approach that I've been using on my daily practice. So, we begin by saying, is it for every case? Do you think that MIS spine or for lumbar spine surgery, is it for every case? So, lumbar disc herniations without response to conservative treatment, only patients with radiculopathy alone. We do not expect to treat axial pain with these techniques, at least for the ones that we are dealing here. Some foraminal or spine injections are performed previously to confirm or even trying to extend a conservative treatment, and extruded discs presented on MRI and CT or protrusions causing unilateral symptoms with a positive correlation between the films and the physical examination, and a stable spine. So we're dealing with intractable or refractory pain. And a stable spine. And we do a lot of planning, a lot of correlation, a lot of examination of these patients and discussion with them to even begin remotely propose a treatment for that. Okay, so we're planning, we're discussing, we're viewing our films, we're talking to the patients, we're dealing with the pros and cons of each technique. We're dealing with potential instability for this kind of cases, these spines. So what's minimally invasive spine surgery? What is the definition? Obviously, it has no specific meaning or definition. It implies a lack of severe surgical invasion with better results and less aggression to the patient. And MIS techniques, obviously, they utilize more technology, they utilize more advanced imaging techniques, better medical equipment to reduce tissue trauma, less bleeding, less radiation exposure, and decrease hospital stays, obviously, by minimizing the size of the incision. What I mean with these slides. So, are we asking the right questions to the patient, or are we proposing the right plan for the treatment for these patients? Aren't we just trying to sell to them something like a sales pitch, something that's more innovative, more technological, with less bleeding, with a smaller incision, with we're trying to sell them a newer model of iPhone eventually. So in spine surgery, if you live it, if you operate enough, you know that there are some novelties and there are some techniques that just don't apply anymore. So we're dealing with a complex patient, with a pain patient, and we should try to avoid some kind of promises. So what I mean is just promising like a smaller incision or going home to the very next day or even the same day after surgery. Is this enough to justify a better surgery? So I began to research, as everyone else talks about in every single talk about endoscopy. We have to change a paradigm. We have to deal with paradigms. We have to change the way we think about surgery. So I went and I researched what is to define a paradigm. So I came across some work from Thomas Kuhn. He's a researcher, a philosophist from Harvard and then MIT in the 70s. He defined paradigm as a universally recognized scientific achievements that for a time, they provide model problems and solutions for a community of researchers. Okay, all right. So what is to observe and to be scrutinized? And the kind of questions that we are supposed to be asked and probed to answers in relation to this subject, and how these questions are to be structured, and how the results of that scientific investigations should be interpreted. So paradigms, they gain their status because they are more successful than their competitors in solving a few problems that the group of practitioners has to come to recognize as acute. Okay, so we better change the paradigm. So this new technology, these new advances, they should eventually change the way we think about the science, about the philosophy in spine surgery as we evolved. Every new field, like in this Thomas Kuhn cycle, they begin with a pre-science. They begun to focus on a problem area, but they are yet capable of solving or making major advances. So, like if we do to apply this to endoscopy, we begin with the blind surgery, the percutaneous surgery, as we advance through Cambin's triangle, just to try to decompress a protrusion or extrusion without even looking at the problem, without even looking at the disc or even the nerve. And efforts to provide a model of understanding that works eventually bear fruit, normal science, where it tends to stay longer than any other step. So we begin to rationalize and think over how we do lumbar disc spine surgery for the past years. How can I improve it? What would I do to improve it? Can I change the pre-science? Can I change the science involved? And over time, the field digs so deep into its area of interest, it discovers new questions its current model of understanding cannot answer, as more of these anomalies, the violations of the expectations, appear as the model grows weaker. This is the model drift. So it's a cycle. It's an eternal cycle of discussion and interest over any other topic. So if enough unsolved anomalies appear and the model cannot be patched up to explain them, we reach the model crisis. And then a new model of understanding one or more viable answers, they emerge, which begin the model revolution step. It is a revolution because the new model is a new paradigm. So let's change the paradigm. Let's discuss about it. Once a single new paradigm is settled on by a few influential supporters, the paradigm change step begins, old versus new. This is something that I had in my mind over the years. I've been doing lumbar spine surgery for at least 12 to 13 years. So I came across these different instruments and these different retractors and these different techniques. And because we see them every day and because we do this every day, we kind of let to observe that, well, if I do it with a Taylor retractor, or if I do it with a MetaRx tubular retractor, which is more technological, or even a Casper retractor at the bottom, Are the results too different? Are we expect to change so much of the pathology or apply this to a soft disc herniation or to recovery to this patient? So the microendoscopic discectomy and tubular access, this article tends to give a historical perspective and some current technical considerations. The first reported case was by Dandy in the 1929, and then 1934, and then from 77, Casper and Yazargil, they provided the use for the microscope. We as neurosurgeons, we tend to know who Yazargil is because of his great advances in microneurosurgery. So for the orthopedics, he's like some sort of Jesus for us, all right? So we try to look at him with a lot of awe and development over the techniques he developed over the years. And since 78, the biggest retrospective of cohort of patients is Dr. Williams in the United States with 532 patients. If you look at the slides, you see that patients, they are urged to begin ablation the first 23 hours. They are discharged the following morning. 95% of the patients return to work within a month of the surgery. Oh, sorry, something. So it's kind of what we do every day, kind of what we do on our daily practices. Patients get up from the bed, they start ambulating, they're discharged from the hospital in the first few hours. That's good to excellent pain relief. Okay. The tubular access, I came across with this article. This is a modified Taylor retractor in a unilateral superior-stow approach. So we came back to the Taylor retractor in a recent paper published by these authors. They just show that a single blade modified Taylor retractor is practical. It costs like $1 to make. It's user-friendly, and it's economical alternative to the existing tubular retractor with similar clinical outcomes. In this review, the tubular microdiscectomy, the techniques, the complications, the complication avoidance, the review of the literature from 317 manuscripts, it tells us almost the same. Complications from tubular and the microdiscectomy, the standard microdiscectomy, are the same. The number of patients are almost the same. The bleeding intraoperatively for these patients is almost the same. The pain, the post-operative pain, is almost the same. And then this is from the tubular microdiscectomy point, a great review of the literature. And every prospective RCT, randomized controlled trials and they have showed exactly the same thing. Level 1 data indicate similar safety profiles, and they indicate lower blood loss for tubular microdiscectomy. And of course, future studies should examine the comparative value of these procedures. And in the bottom, we see, as marked B, a great decompression from a tubular retractor. So this is what I've been researching, this is what I've been studying, and this is what I've been proposing to the patients. The Airbus protocol is a protocol they have been implementing in hospitals the last couple decades to prevent pain, post-operative pain, to regain ambulatory surgery. They are discharged within the few hours after surgery, and then we see these papers that they classify the transits in outpatient minimally invasive spine surgery. Is a reality. It's a refinement of the MIS techniques. They have increased pain management practices, and of course, the precise selection of patients for ambulatory surgery. while an excellent option for some patients could result in suboptimal results for others. So this is a case from Dr. Alfredo Giroy from Argentina. This is a tubular decompression he made from L5S1 herniated disc. So you see like minimal displacement of the structures, absolute control of the bleeding or without any bleeding at all. You see just gaining access to the structures, decompression, and later on we will see a decompression of the soft herniated disc inside canal. So is this enough? I don't know. Will the science tell us differently from these coming years? Will the technology change so much that we will just try to change or improve our daily practice? That's what I love about endoscopy, and then we just have to question ourselves: can we do it better? So what about other options? This article is very interesting. It tells us about the regional variations in acceptance and utilization of minimally invasive spine surgery and techniques among spine surgeons, a result of a global survey. From you can see like 70% of the patients of the surgeons that responded to this questionnaire, the thing that minimally invasive surgery is considered a mainstream in your area. 70% of them they tell them yes, but only 35% of them they have gone full endoscopic or transforaminal or interlaminar with a 40%. So in Latin America or in North America and Europe, they have this almost the same distributions of minimally invasive and using endoscopy. Like almost half of the surgeons they do, half they don't, half defend, half of them they just don't apply to their daily practice. Almost 86% of the surgeons they tell us that they have done minimally invasive spine surgery, with almost 42% of them doing with tubular retractors, almost 60% with some sort of endoscopic surgery. So it's kind of a contradiction for me, because we're dealing with surgeons who defend they practice minimally invasive spine surgery. Only 40% of them using tubular retractors, only half of them using endoscopy procedures. So we go back to the bottom of the question. What are we doing? Is it minimally? Is it endoscopy? Is it tubular? And more important than anything else, what are the results? Are we achieving better pain control for these patients? Are we achieving better results for the patients? Are we not just adding more time, adding more costs to these patients? So,
hey, Bruno.
Sorry.
Yeah, hey, Dr. Saciloto. So I thought that if you go back one slide, I thought that the survey results were actually really interesting and surprising to me. You know, and that more people are doing endoscopic surgery than are doing mini open or tubular surgery.
Tubular retractor.
I think that's pretty surprising, and maybe not necessarily what we see in the States. Do you think there's geographical variances there? Or,
of course,
I suspect in the US.
In Europe, they do more endoscopic surgery. Europe and Latin America, they are almost the same. In US, it's more with a tubular retractor or MIS surgeries. And in Africa, they do the low-cost option, which is during the unilateral approaches and decompression with reducing the size of the incisions. They can do with their kind of equipment. So eventually a microscope, but without so much technology involved, because in endoscopic surgery through this last couple of years, it has grew to larger equipments and more technological, and they are always you just want one use only. You just have to dispose them, so it's very expensive for some countries to use on a routine basis.
Maybe I'll call on my co-hosts, specifically Dr. Malagani, who's European, and Dr. Giroy, who's South American like you. What trends in terms of MIS surgery are you guys seeing in your region?
Yeah, hello from Switzerland. Yeah, I'm a little bit surprised, like you, Coy, because these are high numbers. 60% endoscopic surgery. I just can't talk for Switzerland, and I guess we're like 10, 15, 20%. It's a minority is doing endoscopic. I think it's a good data because 50 and 95% are male who are answering, so it seems to be a very realistic population. So in my region, endoscopic is on the rise, but still it's a minority.
Great, keep going, Dr. Saciloto.
Okay, thank you, Dr. Khan. So as we talked earlier, do we need another option? This is a stenosis of the lateral recess. I did on a patient, like a 60-year-old female. I only took two stitches to the skin. Patient got home the same day after surgery. It took like 100 milliliters of blood intraoperatively. So do we need another option? Is it relevant to search for that? So endoscopic spine surgery, it began from the blind percutaneous endoscopy through Cumbing's triangle. So now we know that the Cumbing's triangle of safety, it has no safety whatsoever. It has lots and lots of danger involved. Engineering has played a crucial role in this evolution with advances of illumination, instrumentation, and have allowed surgeons to work efficiently in smaller and smaller corridors. And the adaptation of enhanced recovery for surgery protocols have completed the benefits offered by spinal endoscopy. So as we progress in time, we got better instruments and better illumination and better visualization of what we are really doing. But we just have to do with lots and lots of equipment. So we are dealing with endoscopy tower and a C-arm. If you have like a poor quality camera involved in your endoscopy set, and you're set with a poor quality image, you have to maintain all those instruments. I have more than once broke some pituitary rongeurs that are used in this discectomy because they are too flimsy, they are too delicate, and eventually they can break intraoperatively, and each one to replace costs like $4,000 to $5,000. So it's a problem. And the full endoscopic spine surgery, this is a narrative review of the full endoscopic spine lumbar discectomy using interlaminar approach. So step by step, the incidence of dural tear has ranged from 0.1 to 8%. Of course, the incidence is higher in revision surgery. The infections in full endoscopic surgery, there's really not a single report on that, because eventually the incision is so small that you won't infect it, and there's a constant flow of saline solution inside your field of view, so eventually we won't infect. And interlaminar endoscopic has a long and steep learning curve. It has some surgery-related complications that are strongly related to the experience of the surgeons. So if you ever have had one dural tear in your endoscopic lumbar surgery, it's very, very difficult to manage, and you have to have not only experience, but good equipment and some glues, and even try to convert your procedure to an open one eventually, if the puncture and the dural tear is to extend. So eventually you have to deal with these complications when you're doing this on a daily basis.
Two things. Hey, Amna, I think one thing is maybe we could make Dr. Gardocki a co-host, because I know he does a lot of endoscopy, and he might have some ideas on CSF leak repairs. But Dr. Saciloto, could you walk through sort of your algorithm towards repairing these CSF leaks endoscopically?
Endoscopically, I'm just trying to use some fatty tissue from the subcutaneous, and just to reduce the volume of saline injection that we're using, or just to stop at all, because eventually, if you have an older patient with CSF fistula, CSF tear, and then you continue to inject saline solution, it will open up, it will blow up like a balloon. So just stop the saline injection at all eventually. I never try to stitch or use like these stitch techniques. My equipment is not capable of doing such things. I only try to open up the bone or a little bit more, and just to do like with some fatty tissue, just to plug inside the dural tear, eventually with gel foam or over it, just because when you're doing percutaneous surgery, your dissection on the subcutaneous tissue is not existent at all. So whatever you do, it just will stay there. It won't accumulate some fluid or CSF on the subcutaneous region.
Yeah, I've heard different things. You know, I've seen, and again, I don't do any. I'm waiting for you to convince me. But you know, I've seen some people leave it unrepaired endoscopically just because the dead space is so small. And I've seen some others just like
I did it in two cases. I didn't do anything. One transformed into an epidural hematoma. I had to open it again with a tubular retractor and decompress it further and repair the fistula, the CSF tear. And the other one was a very old patient. He developed like a caudal peripheral neuropathy, like a compression for all the nerves involved in the fistula. I had to open it again. So since then, I never left it unrepaired, and I try to go. I try to go a little bit slower with the shaver and the drill, trying to avoid and beginning from the bottom of the lamina and going upward, not going through lamina. So when you go through the lamina, you just almost end up with a dural tear.
Dr. Gardocki, what are your thoughts?
Well, so I will say one thing about endoscopic surgery is the visualization is so good, and you have angulation on your camera, so you can always change your view to make sure you can see the tip of your instrument. It's when you get in a hurry or try to cut a corner and you don't take the time to change your angle, that you're more likely to tear something. So, you know, the best ounce of prevention is worth a pound of cure here. In terms of sewing these things, like it's just not been an issue. Now, I do not leave them unrepaired. Like, I don't just do nothing. At a minimum, I'll put a blood patch in, typically some sort of fiber and glue or sealant. If there's a larger defect, you can typically take you know, like a collagen patch and either onlay it and then put some glue on top, so it's like a cap on a jar. Or there's some reports, some of my colleagues like Christoph Hofstetter has talked about having a larger defect and making a little sandwich where you actually put a little piece inside and put a piece outside and kind of sticks to the dura, and you make a little sandwich around it, which I've actually used on a tubular case once and actually worked really well. But you know, step one is don't do it. And it's easy. It's easier to not do it with the endoscope, because your instruments are much more precise and your view is so much better.
And go easy on your drill, right? Because if you just go just too deep with the drill, you'll get up. You might just tear it right on the lateral side on the portion of the facet. Or sometimes there are some adhesions there, and you just nick the dura, and you end up with a CSF tear.
Yeah, I have a endoscopic chisel. It's like a little chisel / gouge. So I like to thin the bone and not actually go through it, and not try to detach things completely, and then use the chisel to sort of break the piece of bone off. That also leaves a piece of bone attached to your ligamentum, so you can start taking the ligamentum out and block, rather than trying to, you know, kerosene bite mop ends, which is frustrating, open, tubular, or endoscopic.
Yeah, I had a professor from here from Brazil. When I trying to use the kerosene punch endoscopically, he always come to my shoulder and tells me the kerosene with at the endoscopic level is not the same as in the tubular retractor one, because it's a punch. You do not try to decompress bone with it. You just try to do a little bit of ligamentum flavum, ligamentum yellow ligament removal with it. It's just too delicate of an instrument, and eventually you can puncture through your dura with it.
Great insights. Please keep going.
So this is a 2-year result for 331 patients using a 6mm endoscopes. The results of between 75 or 100% of the patients with the same results of the microscopic assisted procedures. The avoidance of reduction of resection of spinal canal structures, which enables the minimally traumatic disc resection appear capable of reducing operation-induced segment instability. Operation time, tissue traumatization, and complications are low compared to the conventional procedures. And post-operative MRI examinations show no scarring in the access area or extending to the epidural space. The epidural lubricating fat tissues, they are preserved. So you see down there in the figure 6, the results from leg pain, back pain, and the osvestry are quite good. Eventually, at 2 years of follow-up of these patients, and on the top we see the image of a great decompression using the endoscope after the removal of lumbar disc herniation. So the full endoscopic spine surgery, the full endoscopic one, it has definitive benefits over conventional microsurgical techniques. This include better and clear vision of the pathology due to the presence of irrigation fluid channel. And I like to emphasize this when you're doing the endoscopic procedure. There's no view like the endoscope approaching the nerve, and you see all the inflammatory tissue around the nerve, all the epidural adhesions caused by the lumbar disc herniations. So you just don't see it on the microscope. And we have a relative easily approached deep city pathologies like thoracic disc herniations, and possibility to avoid eventually avoid fusion surgeries. The purpose of this was to describe their benefits, etc. And the full endoscopic spine surgery, it's maybe one of the fastest growing techniques, with better intraoperative visualization, lesser incidence of complications, with faster recovery time, etc., etc. So, with better patient outcomes and eventually reduce medical costs. Here in Brazil, we're trying to do it, but it is an expensive surgery nonetheless, because we have like the endoscope, the instruments, and the tower with all of the equipment, so it's very expensive. This is complications associated with initial learning curve. It's interesting because it's a result from 528 decompression procedures from 6 publications. It's a systemic review. 5 studies have level 4 evidence and 1 have level 3. All of these cases, 190 microscopic endoscopic cases, 282 tubular microdiscectomies, and so much more of endoscopic lumbar discectomies including this review. They say that the equilibrium comes at the 30th case that you do with these new techniques. So eventually you have to do 30 interlaminar decompressive surgeries to reach it's a term they use in statistics, that's asymptote, which is an equilibrium without any further complication, without any further problems associated with the surgery, and causing as good as the last technique involved. So it answered one of my questions: how much cases do I need to be before I'm comfortable with doing this technique? So statistically, it's 30 cases. This is the table involved in that review. So the sample size comes from 35 patients to 230 patients, from the microendoscopic discectomy, microdiscectomy, and MIS laminectomy, from even MIS TLIF patients, eventually tubular microdiscectomy, and etc. So,
Dr. Saciloto.
Sorry.
There's a great question from Dr. Burchuk, who's one of our regular listeners. And the question is, how many of the 528 patients went on to require fusion at the operative level? And I think a nice segue to that is, was there a difference between, the different decompression techniques?
It's not this was not a review done accompanying those patients as an evolution. It was the primary surgery they were submitted to. So these cases, like this sample size from Lao with MIS TLIFs, it was just the first surgery they were assigned to. So it was not a patient who had done surgery previously. It's just a quantification of how many cases he must have done to reach that the least probability of complications. So you do like in endoscopy, it's 30. In this case, in this review from MIS TLIF, in the initial 10 cases. So each one of these sets of patients, they have their number to begin with, not adding more complications, not adding more problems to the patient, and gaining only the benefits of that specific surgery.
Okay.
So this is an article published in 2021 is it time to change from the fully endoscopic lumbar spinal surgery? Is rapidly evolving. The process being driven by patient demand, because that's what I was talking earlier. Patients are often driven to these techniques because they see on the internet, they see on the publications that this is a newer technology. This is something that's new on the market, and eventually promises them to return to work earlier, the smaller possible rehabilitation time. And there are also advantages to be had in the form of decreased incidence of later instability, eventually as a late complication. We do not have answers for that yet. Eventually, because patients are too different from one another, we just cannot compare the randomization of these patients are so complicated, and eventually to do a randomized control trials. And the technique has the potential to live up to all of these expectations. However, they are associated with a significant learning curve that we see on our daily practices. Once the techniques have been mastered, it has significant advantage for all of its populations. This is for what I think, for me, is the main reason we should see better results with the endoscopic spine surgery. Mainly because of the saline injection, the continuous saline injection in your field of surgery. Because all of these inflammatory responses associated with the reabsorption of the herniated discs, so macrophages, they release MMP3s and vascular growth factors. They produce revascularization. To all of this inflammatory response locally on that level, which occurred, the disc extrusion is what eventually will discharge all those nociceptors, all those pain receptors to begin pain and chronic pain and sensibilization of all those receptors through time. So eventually, with the saline injection and with you have the option to wash it off during surgery and dissect it with more precision tools. We're using the endoscopic procedure than we do with a microscope alone. So eventually, you get a result like this with a retraction of the endoscope and maintaining all those intact structures and dealing with a disc fragment which is being removed at one piece, and other pieces they were only inflammatory or causing inflammatory response on the epidural space, and of course the result in an aesthetic result is the best possible. It's only one stitch to the skin of this patient.
Dr. Saciloto, just to challenge you a little bit, you know, I use a tube and I don't irrigate much, but what's the difference between just you know, regularly irrigating throughout the tubular case?
The volume, I think so. Because when you're doing endoscopic procedures, you utilize as much as 7 liters or 8 liters or 10 liters eventually if you have any bleeding on the epidural space. And with a tubular retractor, eventually you wash it off like 20 or 30 millimeters of saline solution. So I think the volume is the main difference for the spine procedure than the tubular.
Well,
Okay.
may I say, Dr. Saciloto, may I ask, or may I mention? I think the irrigation is really key. What makes a difference? The irrigation is used to compress some veins, so it's less blood loss. And when you once have to go again into the situs where you have had performed endoscopically surgery before, you don't find a lot of scar. So there's a big difference between an open tubular access and an endoscopically access. It's so little scarring. It's really really good. And when you look at the back pain post-op, there's so little back pain. The wound is not aching a lot. The patients are getting up the next hour or 4 hours later in the awakening room. So it's really speed. And I think the blood in the situs, which is minimum in endoscopic, and in tubular it's a lot more, makes a difference in pain and scarring. This is my personal opinion.
Yeah, I think so, because when you're just, I had the opportunity to use one of the first generation Destando retractors from Escolab. I know it's not it's an endoscopy set that doesn't use any irrigation. It's more like a tubular retractor with an endoscope. It's almost the same as the microscopic procedure, but you use an endoscope. The postoperative pain on the patient is almost the same, because you just don't dissect it as much as the tubular retractor. But if you see the scarring process on an MRI, on a post-op MRI, is far greater from if you compare it to the endoscopic procedure. The endoscopic one, you just don't see almost nothing. The counterpart of that is the access is much smaller, and eventually, if you do not have some experience, you might not decompress it enough. That's something that you might want to see onto your post-op MRI. Eventually, you just will see some scarring tissue that you think it is, but it's only residual fragments from the disc, or eventually decompression that is not done so effectively as it should have. So because if you look at those slides that I'm showing you, they are all tall discs. They are all patients. I did a case last week, and a 23-year-old patient. So a patient that was, I tried to do some spinal injections. Eventually, he said to me, "Doc, go ahead, take this thing out, because I just can't get it. Just can't bear with the pain again." So it has some difference on the approach. It has some difference on what you're expecting to do on these patients. The patient selection. Eventually, 2 levels are okay. I didn't do many cases involving the decompression of 2 levels to answer this case, these cases. Dr. Raymond, I think you have any opinion on that subject? Doing 2 level surgery?
I mean, occasionally it's necessary if you're talking about for a discectomy, but typically there's one disc that's the primary cause of the pain, and addressing that is the ultimate goal. Now, there have been times where I've done a disc, like I had a patient recently who did a transforaminal discectomy, had some improvement. 2 weeks later, it got worse. Actually had another foraminal herniation at the level below, and had to take them back. But taking them back for another surgery, they come in, I do them awake, so they're not even under general anesthesia, and they have no restrictions a couple days after surgery. So, this is more like having dental work done than having spine surgery. You come in, you bounce back, you're there for a little bit. When you go to the dentist, they don't like pull all your teeth and give you dentures if you have a cavity. But that's what we do in spine surgery. Yeah. We literally Like the question from Dr. Burchak about, do these patients go on to fusion? Well, some of them definitely do, because part of that is the natural history of the disease. Some of it is the more of this you do, the more times you will try to do an endoscopic case in a patient that would benefit from a fusion just to try to avoid it. But the patient eventually going to fusion isn't necessarily a failure if you can put that out for a few years. If you can take somebody in their 40s and delay them into their 50s to have a fusion, that's a win. I've had a couple patients this week that were recommended multi-level fusions, and I did one-level decompressions specifically in the foramen, and they were better. Now, if they have a fusion 3 years from now,
so be it.
So that we bought them 3 years.
At least, yeah. That's
now, Ray. I've heard from sorry, Dr. Gardocki. I've heard from people like Christoph that these foraminal stenosis patients are pretty routinely coming back fairly quickly for fusion surgery. Has that been your experience as well?
So it depends on what you're doing. So it's not a general panacea for all foraminal stenosis. And from what I can see, the patients that have like a fractional curve, and you're talking about the compressed side, the compressed foramen, and you've got up-down stenosis, that's not something that's going to do well, because when you remove the structure there, it's just going to collapse further. But people with straight spines and no significant fractional curve at the compressed site seem to do pretty well.
Great. There's a question from Dr. Burchak. Sorry, I'm on my phone. Are there any studies that compare endoscopic foraminotomy, especially using a contralateral approach, versus TLIF? I don't know the answer to that question. Bruno or Raymond, do you guys?
So a contralateral foraminotomy versus an ipsilateral TLIF? No, I'm not aware of anything that's specific. I will tell you that I frequently see patients that have foraminal and far lateral herniations that told they need a TLIF, that we remove the herniation endoscopically, and it resolves the radiculopathy. And those are. I think that's one of the issues with spine surgery, right? So you'll have somebody that has 3-level degenerative disc disease, a single-level far lateral disc herniation, a single-level radiculopathy, and that patient gets a 3-level front back fusion. That's what we're trying to avoid with this.
I did have one question for Dr. Saciloto. Here, your rongeur is pretty deep into the disc space. Are you just is this just this patient and how sort of deep those free fragments were, or are you being sort of intentionally disruptive here?
No, where the fragments were. Eventually, that's something I got used to doing over the last couple of years, because just to prevent some sort of re-herniation. So I go deep and I wash it off with lots of saline. And eventually, just some free fragments, they just emerge. So it's just trying to avoid some free fragments deep in the disc. So I didn't see any collapsed discs over the years doing this, or more collapsed discs. As Dr. Raymond said, just from 2 level, I'm kind of skeptical, at least. But at least I'm trying to offer for this patient, which is like, I think he has 28 years of age, I think, some sort of treatment that will free some of his pain, or eventually give him some time off of those meds, and push those fusions at least for 5 to 10 years to the future. So eventually, that's a more like an attempt to give this patient some free time from pain and whatever.
Great. Well, we have about 5 minutes left, Dr. Saciloto. So why don't you kind of, perfect timing.
Oh, yeah, take home message. So that's what we're talking about, this plan your surgery, select your patient properly. I left this image at the bottom on purpose, because eventually when you're doing or dealing with some inflammatory response in the epidural space, some patient who has been submitted to like 3 or 4 spinal injections on the last year or something like that, and you see lots of inflammatory veins and blood coming from the epidural space that you just can't control, because it's a uniportal equipment, because you are only doing something from one port. It's not a biportal like when you're doing microsurgical decompressions with a tubular retractor, you're doing with both hands. So eventually one can control the bleeding and the other one can use the sucker on everything else. When you're doing endoscopic spine surgery, you're just with one eye and one instrument. Occasionally, when it happens, this blood all over the place, so you just can't see anything. You just have to take a deep breath, increase the saline solution. I don't know, pray if you're religious. You gotta just keep calm and just try to find the vein that is bleeding. Like Dr. Ray said before, you can look in some other directions, going up and down, and just try and find. Never go deep inside the canal. Eventually, you can rupture your dura, eventually compress any nerves. So it's another technique. It's another way of thinking. It's another way to decompress the spine. It has some of its peculiar and troublesome moments, but eventually it's a viable option for some patients, and we can aggregate some pain-free time for them over the years.
You brought up something I want you to expand upon. I guess unfortunately I do a lot of journal review work, and it seems like every other paper is uniportal, biportal, however many ports. So what are pathologies that are beneficial to be uniportal, and what are pathologies that one should learn the biportal technique?
I never done the biportal. I've never seen it. I think it will be the future. I think eventually for tumors and something which needs some more manipulation or the dissection, it's going to be more effective. Just have a fixed camera and the other portal doing all the instruments. I don't know what's going to be what the future holds for this kind of pathology. There are some techniques that use some percutaneous decompressions associated with endoscopic procedures. You do like a percutaneous decompression, a blind decompression, and you insert the endoscope afterwards. There are some extra steps. There's some people who do it, there's some people who don't, who find it more aggressive to the spine or even riskier. So we were just talking about lumbar disc, herniated discs on the lumbar spine today, so mainly soft discs. But I think it should be in your surgical armoire, like a different set of glasses, like a different set of loops, or the different. It should be on your options. So at least to consider on some patients.
Great. Well, that was a great presentation, Dr. Saciloto. It seems like you're on vacation. I appreciate you taking the time out of your vacation to spend time with us, and I think it really facilitated a lot of great conversation. So thanks everyone who was able to join tonight, and look forward to seeing you all next week.
Thank you for the opportunity. I hope you just have. I hope you have so much fun than I did. reviewing all these topics. Thank you.
All right, good night, everyone.
Thank you.